during summer.
All right, we're going to talk about diabetes, or the sugar. Diabetes was first discovered in 1500 BC. It actually, diabetes stands for, let's see, honey urine. And how they noticed that these people were getting really, really skinny and having to pee all the time. And so they actually would taste their urine, and it would taste sweet. Luckily, we don't have to do that today. Luckily, we have dipsticks, so we don't actually have to have a urine taster anymore. Let's see, insulin. Insulin was discovered in 1920. So we had to wait that long, and we lost that many people until we figured out what was going on. Let's see. There are an estimated 20.8 million people with diabetes, and it's probably actually higher at this point. 10% of this is type 1. 90% is type 2. Y'all can believe that now, can't you? This day and age with all the children that are obese and all that. It is probably the leading cause of death, even though they'll say heart disease will be the leading cause of death, but the diabetes contributes to that heart disease. So I know that diabetes is a contributing factor of a lot of the deaths. So, where is insulin made? In that pancreas. And there's some islets of Langerhans. In the beta cells. Or insulin made. Now, anytime you and I eat something, the pancreas gets stimulated to release insulin. Okay, to help get the sugar and the carbohydrates into our cells. Okay. When a diabetic eats, they don't have that. They don't have any insulin. So the sugar can't get into their cells. So, let's look at what insulin actually does. Okay, insulin is a key. So here's all these little cells, and they all have a keyhole. Okay, so whenever you eat, pancreas releases insulin. The insulin turns the key goes in the keyhole, and it opens the door, and that way all the sugar can go in. Or glycogen. All cells need glycogen to function. Muscle cells, liver cells, all cells. Okay. So, in order for our cells to live, we have to have this insulin that will open the door. Okay. Insulin happens in two ways. We have basal insulin, and we have a postprandial. Basal insulin It's a slow, constant drip into the bloodstream. So it's constantly just dripping, dripping, dripping to help keep our blood sugar levels at a normal level. What's a normal blood sugar level? So, this is constantly being dripped. Even right now, since we're not even eating, we're having a basal drip of insulin going into our bloodstream. Okay, postprandial is after we eat. That's when you get like a bolus of insulin. So this bolus of insulin takes what we just ate, takes all of our McDonald's that we just ate, and the insulin will put all the keys in the door and put all the McDonald's into the cells. So we have fuel for energy, right? Does this make sense? Yes. So that's what happens in postprandial. Now, have any of us gotten sleepy after we eat? That's because we have more carbohydrates than we have insulin. So it makes us sleepy because we're basically eating too much. There is another place in the pancreas, and it is an alpha cell, and it makes glucagon. Now what glucagon does is if our blood sugar goes below 60, glucagon comes out to release stores of sugar glycogen to increase that blood sugar back to this range. Okay. This is like even if I bottom out, I'm not diabetic, but if my blood sugar bottoms out, I may look diabetic, but I'm not. At least I don't think I am. So even if I don't eat for a long time and my blood sugar starts to bottom out, my own pancreas will start secreting this glucagon to help break down some of the stores of glycogen that are in my body to get my blood sugar back up. There's also a shot form of this, or an injection form of this, that people with diabetes can carry with them, and they can give themselves a glucagon shot to help get their blood sugar back up. So, diabetes, we either have a defect in the pancreas, or we have a defect in the insulin. Which type has the defect in the pancreas? Type 1. Who has the defect in the insulin? Type 2. So, type 1 used to be called insulin-dependent diabetes mellitus. That's what it used to be called. It used to be juvenile onset only, but now anybody who's under the age of 30 is now type 1. They have to have insulin. They cannot take oral meds at all. They have to have insulin. Okay. Their body makes no keys. Their body makes no keys to unlock the doors. Okay. Now, with type 2, let me tell you all why. Now, type 1 can be caused by autoimmune. An autoimmune disorder somehow. The body just starts attacking its own pancreas. Or they have linked a lot of type 1 to viruses. So, you can do a pancreas transplant in type 1 patients, but if you put a new pancreas in, the same problem that destroyed the first one will end up destroying the second pancreas. So, I think they've kind of gone by the wayside a little bit. So, type 2, they have insulin. They have insulin, but either their keys are bent, and it's hard to get into the door, open the door, or the keyhole is bent. You can bend the keyhole, I don't know. But, so either it's hard to get in, or you've got the insulin you can't fit it in the keyhole just right.
Don't they also, they'll produce the insulin, but it'll be not enough in some cases as well?
Yes.
Just,
So they can also have insulin, but they don't produce, they don't produce enough to cover what they've eaten, in a sense. Does that make sense? Also, the more you eat, because we have a problem obviously with obesity nowadays, the more you eat, it wears out the insulin, constantly having to stick keys in the door and open the door, constantly having to do that. So eventually the insulin just sort of gets worn out. And the receptors don't work as well anymore, and the insulin just doesn't work as well anymore, so eventually. So type 2 usually starts out with oral, but lots of them do progress to having to take insulin shots. There is another type of diabetes, and that's gestational, and that occurs when you're pregnant, and that would be more covered in the mother-baby unit. Let's see. So, classic signs and symptoms of diabetes. How do you know somebody's got diabetes? What else do they have? Thirsty. Holly did see it. What else do they have? They want to eat all the time.
Yes.
These are the 3 P's of diabetes, the hallmark sign of diabetes. Now, with type 1, they will be, they'll be skinny. Hungry all the time, peeing all the time, drinking all the time, drinking water. But they'll be skinny. Now the type 2, what do they look like?
They're usually overweight.
Typically overweight. Now, a type 1 diabetic, they will get to the doctor quick. Because something's obviously wrong. You're eating and drinking and peeing all the time, but you're still losing weight. And then you probably start getting ketones building up and you start smelling like nail polish remover. So that usually gets you to the doctor pretty quick. Or else they go into a coma and they end up in the ER that route too. So, now, type 2 don't make it to the doctor until they're immersed in it. Usually what sends them to the doctor for type 2, bladder infection, eyesight, diabetes. My eyesight is going bad. They're having trouble seeing, so they go see their eye doctor. Also, they might have a wound that won't heal. So that's what gets them to go see the doctor. So then they do a fasting blood sugar, and now they say it has to be less than 106 for fasting. Although they're actually thinking about going away from doing those fasting tests because that just shows one picture at one day and it doesn't necessarily tell the whole story. They used to do those, and they still do them, the oral glucose tolerance tests. That's where you drink something so syrupy, sugary, sweet. And then they check your blood sugar levels like 3 hours after, and like 6 hours after, something like that. But they've gotten away from doing that also. So now they look at what's called a hemoglobin A1C. And this is over a 3-month period. So, a red blood cell lasts for 3 months. So, they go draw a hemoglobin A1C and it'll tell what their blood sugars were like over a 3-month period. And it'll be like high, low, high, low, high, low, low, high, high, low. Looks like an EKG. Or if they stay pretty normal. Okay. You want your hemoglobin A1C to be less than 7%. And you want it to look like that. Smooth sailing. So, there was a study, it's been several years, but the average hemoglobin A1C was 11. They've now got it down to, I think, close to 9. Still high. So, 7 is where they want to be. They used to also think the tighter the controls were, the better off it was, but they ended up like causing like too much stress on the body. So, I mean, they're kind of, instead of being so strict about how they keep their blood sugar, they have a little bit more wiggle room, and they said that they turn out better. So this is more what they go by now. Questions so far? No? Okay, good. Oh, good. Y'all know it then. Let's see. One thing about type 2, or a couple of things about type 2. Used to be over age 50. Now, obviously, it's not. Now we know that adolescents now have it, and even young children have type 2 diabetes. It runs in the family, so you can have a family history of it. And one thing that got them to be type 2, not everyone, but usually a lifestyle. Right? What's the number one way to treat diabetes? Diet and exercise, right? Did these people diet and exercise to begin with? No. So how hard is it to get them to do diet and exercise?
Very.
Very hard.
Very.
So, I think a lot of physicians say, well, let's get diet and exercise, but let me go ahead and give you a pill. So, that's just sort of the...
Usually metformin.
Yes, it usually is. Usually it's glucagon. So, you can see the stark differences between type 1 and type 2. They did nothing. It happened. They did something, and it happened. They did something, and they didn't do something. So, and I don't have any room to talk. So. I've actually talked to a person who was type 2 diabetic, and she told me that she was tired of the pills and she wanted to just be put on insulin straight away. And I was like, that's kind of like last resort. Why don't you like diet and exercise and take pills first instead of let's just go ahead and just get on the insulin. So.
Well, I know somebody that actually was on the medication and through diet is completely off now and fine.
Oh, it can happen. Oh, it totally can happen. You put your mind to it. All right. For any diabetes, no matter which kind or type, the number one complication hypoglycemia. Whether you're diabetic or not, everybody has experienced hypoglycemia. Y'all been hungry? Hungry and angry. You've got kids around 4 o'clock in the afternoon. They start getting cuckoo and crazy. They're hangry. Same for us. About 4 o'clock is the witching hour to be hangry. So have some peanut butter crackers ready at about 4. So we all know what it feels like. So it feels like fuzzy headed, right? Can't think straight. You're hungry, irritable, you get tired. Shaky. You get all these things. Now for us that aren't diabetic, we can just go get some food and we can do better. Now, a person with diabetes, if they become hypoglycemic, don't force feed them too much. Okay? Because if their blood sugar is down here, let's do normal. If their blood sugar bottoms out down here, and you start running to give them sugar packets and orange juice, candy, peanut butter and crackers, and just start ice cream and start putting everything at them, what's that going to have to do to their blood sugar? So the higher the spike, the harder you fall. Okay? So, then you're doing, in the hospital, you're doing this, and it's called chasing your tail. So, 15 minutes to start using the food. Takes 15 minutes. So as soon as you give them something that's a carbohydrate and a protein, peanut butter cracker, cheese and a cracker, something like that, it'll take 15 minutes for this to come up. And the whole time you're freaking out because they're shaking and turning gray and sweaty and not sweaty. But you have to wait 15 minutes. So, and it's probably one of the longest 15 minutes that you've waited, but you have to. Don't listen to other old nurses start saying, well, put sugar packets under their tongue, or no. They need a carbohydrate and a protein. The carbohydrate will get in faster, but the protein keeps that carbohydrate at a even keel instead of just shooting it up. So if my blood sugar goes down, I take a protein and a carbohydrate, then it'll be like that instead of going up and down.
How low would it be for you just to use the 15 minutes and not like a glucose push or something?
Well, now, if they're awake and then eat something, they can drink milk too. Milk is a good thing. If they're awake, you can have them eat something. Now, if they're starting to pass out and they're unconscious, then you have to give what's called D50. And it's an IV push. And it comes in a big old round syringe, Bristojet thing. And you have to use 2 fingers or 2 hands and push it. And it's like pushing concrete. So this D50 goes straight into their bloodstream. And makes them real, real sugary. And so guess what's going to happen after you push D50? Going to do this. So they have found that if you don't get so extravagant trying to treat a hypoglycemic reaction, that the less spikes you'll have like that. And you want to try to just be able just to do this with them and then get them back on their little smooth sailing thing. Okay. And then plus, if they do this themselves at home, which they do that. This will tell on them because their hemoglobin A1C will be like 11%. A former student, she had a sister who was diabetic. She was type 1. She wore an insulin pump. And she would go to Golden Corral and eat everything that she could get her hands on, and then just dial up the pump. Wouldn't even check her blood sugar or anything. So I was like, well, I don't know that that's particularly safe or healthy. So the number one is hypoglycemia. I know it's hard to wait the 15 minutes, but don't start checking their blood sugar, sticking them every couple of minutes to see if their blood sugars come up. Because they'll start to come out of it. They'll start to come out of their fog. Because we've all come out of our fogs, haven't we? Mostly. I don't know, sometimes I'm still in the fog. So, does all that make sense? Now, with hypoglycemia, our body will stimulate something called the sympathetic nervous system. And what is sympathetic nervous system? It's your fight or flight. So, this means that adrenaline comes out, and that's where you see you're shaky, you're sweaty, you're irritable. And what this sympathetic nervous system is doing is trying to tell everybody to open their stores of glycogen and get the sugar out. Because the number one organ that needs sugar at a constant rate and doesn't require insulin is not the kidney, because that looks like the kidney, doesn't it? Your brain. My husband's name is Brian, so I always have to make sure I spell brain and Brian the correct way. So the brain does not need insulin. It has no keyholes, and it's got just an open door policy. The sugar, come on in. So that's the one organ that does not need insulin, and they need that constant supply of 60-100 blood sugar. If the brain doesn't have this ensues. So, diabetics need to be able to recognize their sympathetic nervous system when it starts to come on. So. I'm trying to decide where to go next. My head's too full. I know too much. Okay. Now, let's talk about the other side of the equation. All the hyperglycemia. Now, I'm going to go back to fluid and electrolytes. Told y'all that would come back. Here's your blood vessel. You got all your cells. They each have their little keyholes. I didn't do all of them. So, the whole reason a person gets diabetic and has hyperglycemia is that they eat, right? They eat, and it gets turned into glycogen or glucose. So, we have all these little glucose molecules. And so we need the little key, the insulin, to open up the door to put all the glucose molecules into all the cells, right? Does that make sense? If we have no keys, then is the insulin, or is the glucose getting in the cell? What's happening to it?
Staying in the blood.
It's just staying in the blood, isn't it? So then we keep eating. And eventually, it's syrup. Eventually you have a cross between molasses and syrup in there. So here we've got high blood sugar, but what are our cells doing? Our cells are starving, right? So that's why that gives a diabetic polyphagia. Because the cells are like, come on now, feed us something. Of course, the brain doesn't have, the only thing is, if the brain has too much blood sugar, then that's when you get kind of tired. So, the cells are starving because there's no insulin. So then what happens? Well, look at all this. Look how sugary this is. So what's going to happen? I'm going to start pulling. What am I going to start pulling? I'm going to start pulling fluids, right? Because we have to make this even. So this sugary stuff in the blood is going to start pulling fluid from the cells and pulling fluid from the interstitial space. So now I've got all this fluid in here, and now all my cells are, they're all shrunk up, aren't they? Now they've become little raisins instead of grapes. So I've got all this fluid in my vascular space, so what am I going to do? Pee it out. So that's why I've got the polyuria. So now if I have no water in my cells or in my interstitial space, well then now I'm thirsty. Because I'm dehydrated. So the longer a patient stays with this hyperglycemia, whether polyuria, peeing it all out, and staying dehydrated, what can they go into? If I don't have any blood volume or anything. They get severely dehydrated. But they're full of sugar. So I guess they're kind of like a sucker, a gummy worm. So when we have hyperglycemia, that's why they're thirsty, hungry. Pee a lot. Now, with type 1, we have no insulin. So Type 1 has no insulin. So, if they have no insulin here, then they start breaking down ketone, the fat, they start breaking down fats. That's why they get so skinny. And the byproduct of that is ketones. So they break down fats. And then they all start breaking down proteins. So that also makes them skinny. But all these breaking down give them some blood sugar, which will increase their blood sugar even more. So they start breaking these down. Ketones are an acid. So type 1, that will go into what's called diabetic ketoacidosis. So they are in metabolic acidosis. You remember metabolic acidosis?
So how are we gonna correct that?
Well, I don't know. How are we? Now, we just talked about all the ABGs and stuff, about metabolic acidosis, metabolic alkalosis, and all that. So if it's a metabolic acidosis, my pH is going to be acid. My bicarb is going to be at an acid level. So my PCO2 is going to be alkaline, right? And how do I get an alkaline PCO2? Blowing it off. So you will see that they have Kussmaul's breathing. And they will have acetone. So they will have acetone breath, which is a breakdown of ketones, and they literally smell like nail polish remover. It's a smell. Once you smell it, you'll never forget it, ever. So, type 1, right? Does this make sense? I'm gonna get rid of that. Oh. Type 1, how do we treat this diabetic ketoacidosis? We're going to give IV fluids first. I know that doesn't make sense. So they need IV fluids first because they're so dehydrated that they're going to go into shock. They need fluids. Second, they need insulin. And I don't mean like, first we're going to give IV fluids and wait a day. I mean like, IV fluids is our priority. Let's get that started, then let's get the insulin started. So don't start with it, trying to get insulin started and then IV fluids, because they need IV fluids. Or else the insulin's not going to keep them from not going into shock. IV fluids first. What kind of IV fluids do you think? I'll give them a bunch of dextrose. No. They're already high. So we're going to give them normal saline and lots of it.
breathing a lot. Is that what that is?
It's really, it's deep because they're doing everything they can to try to blow off CO2, which is an acid. So they're trying everything they can to get that pH back to normal. That can be fast, but it's usually real deep too.
Okay.
I mean, you can do, but that's not gonna write how far acidotic that they are. I mean, I've seen a DKA come in with a pH of 6.9. And like, their bicarb was like at 8. So, they survived, but apparently it was a girl that liked to, she did DKA lots of times. So, although the more you go into DKA, the less likely it will come out. I mean, being diabetic is probably one of the hardest things you can do. But it is a disease that you can keep under control. It just depends on how hard you want to work to keep it under control. So, type 1s tend to do better with the management of their lifestyle and managing their food and all that.
I think it's because they're younger when they get it usually, and then over time, it becomes habit, and they know their routine, and they know their body.
Yeah. And they also know that if they don't, they will die. You know? Whereas type 2s have just enough insulin to keep them going, I guess. I'll tell y'all that diabetes is one of the hardest disease process for even nurses to like remember what to do and oh yeah, what causes this, oh what, you know, that. So ask lots of questions when y'all get out. Go to seminars on diabetes. And nowadays they are changing stuff so rapidly, all the different drugs that they use now. They now even have like inhaled insulin. They've got these little pods that you stick to you and sort of shoots it in. I mean, it's crazy. I tried the wristwatch, but it didn't work. Okay, so now, with type 2, this still goes on. Erase some of that. Type 2, we still have our sugary, syrupy blood, and we still have our cells. Some have the keyhole, that's okay. Some have the keyhole that's bent. Okay. So we have just enough insulin for them to fit into the keyholes. Not all, but just enough to keep them from going into acidosis. So these bent keys, eventually the bent keys will kind of work their way in to open the door, to let the sugar in. Or the ones that you can't, the doors are bent or the keyholes are bent, you can't use them much anymore. So, but eventually they have enough of the keys to open the door to let it in. So this prevents them from going into, start breaking down all their fats and proteins. So, but they still will have the increased urine output. They still will be hungry. And they will still be thirsty. So, if they've got just enough insulin to prevent ketosis, but they still have enough sugar in here to make them dehydrated. So, type 1's got dehydrated. Dehydrated. They both get dehydrated pretty badly. But since they don't have this ketosis, they don't pass out and go into a coma like as soon as type 1's do. Type 1's, their blood sugar might be 450, maybe even to 600, and that'll put them in the hospital. A type 2 diabetic, I mean, their blood sugar can be upwards of 1,000 before it sends them to the hospital. So by the time their blood sugar gets to 1,000, they are beyond dehydrated. They're even more dehydrated than the type 1. I heard someone call it, it's like they're mashed potato flakes. So they are so severely dehydrated. And what does severe dehydration lead to? Shock. So, what are we going to give them first? They need IV fluids. Even more than the type 1. And they both need it. But they need IV fluids. And then they need insulin also. And if they don't take insulin at home, they will still need insulin IV. Now, any questions about what their main complications are, the big serious ones? Type 2, it's called non-ketotic HHNS, which is hyperglycemic, hyperosmolar, non-ketotic syndrome. Well, that makes sense. If they're hyperglycemic, they're hyperosmolar, but they don't make ketones. Well, this is type 2.
Isn't it harder to get them out of that than it is a type 1 sometimes?
Yes. It is. And a lot of type 2s that are really in HHNS will be diagnosed as DKA. Too. Now, what are the other long-term complications? These are the complications that send them to the hospital. What kind of long-term complications does diabetes have?
Blindness.
Huh?
They go blind.
They
Some
do.
of them,
They go blind.
they have trouble feeling.
And this is for type 1 or type 2. So, blindness. I mean, if you can imagine the little tiny veins in your eyeballs, and it's trying to push molasses through those little tiny veins in your eyeballs. So it's not getting much oxygen perfusion there. What else?
They get neuropathy.
Neuropathy. And what's neuropathy?
It's where the nerves get diseased.
The nerves start not being able to feel. You get tingling. They go numb. They get like numbness and tingling. And if you've seen the commercials on TV, they've got some Lyrica, I think is for diabetic neuropathy.
They'll also give gabapentin.
Yes. Well, yeah, they will. They'll give gabapentin. But gabapentin can also be for chronic pain too. So, neuropathy, numbness, and tingling. Now, where do they get their neuropathy that's pretty dangerous? Their little feet. So they'll stub their toe, and they don't know it, because they can't feel it. And then that turns into an open wound. And then it doesn't heal because they're diabetic. They can't fix their wounds as well as we can because of their protein and carbohydrate metabolism. So always on your care plan, if they're diabetic, make sure that they have a good protein and carbohydrate. That should be one of your interventions, always. So feet. So they'll have a wound they don't feel and won't heal. You can also go all the way up to the legs. They have trouble walking. They take a bath in the bathtub. They can stick their foot in and not realize that it's too hot and scald their feet. They should look at their feet every day, inspect them with a mirror. They have like special little mirrors. I'm not gonna show you. Don't look. And I was out there walking around barefoot in the week. What was I saying about dirty feet? To inspect them with a mirror, they've got these special like long handled mirrors that they can look and check their feet. They also can break their feet bones or foot bones, and they don't know it too until they just kind of like are limping around. So they need special shoes and no flip-flops. They need to have their little toes enclosed in something. And they shouldn't be barefoot either. Now, luckily now orthotics are in style. So, in fact, these are orthotics. So, I'm just glad that orthotics are back in style. Because back then they used to look like Herman Munster from the Munsters. Let's see, what else do they have? Coronary artery disease. There's something about the amount of sugar that's in their bloodstream that starts kind of like, here's a normal blood vessel. It starts like thickening. It just starts like laying down this extra membrane until eventually it starts getting smaller and smaller and smaller. What else do they have? Of course, anytime you get small vessels, strokes can happen.
Also decreases the blood flow, so those wounds So it just makes it even worse and worse, and they wind up losing.
Yes, yes. Since the blood vessels get smaller and smaller and smaller, there's less blood flow going to their wounds, so they also won't heal. If they have less and less blood flow going to their extremities, then they get a wound that won't heal. Amputations. I think diabetes is the number one cause of amputations. And they'll keep going. Start off down here and just keep going and going and going, and you lose one thumb, then you're down to something like that. I've seen that. Renal. It's the number one cause of renal failure. Kidneys quit working. And then also peripheral vascular disease, which ties in with the wounds that won't heal and the amputations. And stroke. Other things that can happen is gastroparesis, where the stomach doesn't want to empty, or the stomach is real slow to empty. That goes along with the neuropathy. Gastroparesis. So slow emptying of the stomach. Periodontal disease. Obviously, if they can't have if their blood vessels, here it is, get so small and even feed into their teeth, and then men end up with erectile dysfunction. So, any other complications? I reckon that's enough.
Yeah.
They
Eventually, one of those will be a joke.
yes. Yes. So, we're so familiar now with, diabetes is just on the lookout. I mean, and you can't take care of a patient in the hospital without them having diabetes.
I had a patient that she was in her early 60s, and they had cut off her foot just above the ankle, and they were waiting for the infection to heal somewhat that had gone into her bloodstream before they amputated to the knee. And she was a sweet person, but I mean, her kidneys weren't functioning anymore. She had to go to dialysis, and she would come back from dialysis sick as a dog, going up. It's not a pretty life at all.
No, but see, that's the thing is you can manage it, but not everybody wants to. Just one thing to remember is if your patient feels hot and dry, their sugar will be high. If they're cold and clammy, they need some candy. I don't mean to really give them candy, but this is just something that you can remember as a mantra. Always hot and dry. Sugar might be high, because they get real hot. Because they're dehydrated. If they're kind of cold and clammy, they need some candy.